Yeah, I will present a very nice case. It's a boy, 4.5 years. He come to me diagnosed as rheumatic heart disease, severe aortic valve incompetence, for possibility of aortic repair or aortic valve replacement at that age. He was NIHA classification class 2 in the past 6 months. By clinical exams, there is a continuous murmur at the left sternal border, normal second heart sound. We can appreciate by the echocardiography that is not true aortic valve incompetence. Here the color flow come from beside the aortic valve. It's not from a valvular aspect. Here also we can appreciate the color flow, and we can appreciate here is this space around the aortic valve, which must go for the differential diagnosis, because this is the first time to repeat the echo after one of the eminent professors who diagnosed it as aortic valve incompetence. So for the differential diagnosis, it could be rupture sinus of valsalva, or rheumatic aortic valve regurg, or aortic root abscess, or patent ductus, or aortopulmonary window, or also coronary cameral fistula. And here the flow looks like the PDA flow, and this is the aortopulmonary window. And we can here appreciate this is pictures, looks like the same as our case, which is aortic root abscess. And for that, we can revise again. We can here appreciate the color come from around the aorta, or the beside the aortic valve. And here actually it's aorta LV tunnel, which come from the upper border of the sinusotubular ridge and open in the aorta LV cavity, left ventricular cavity, which is a very, very rare case. So it's the aorta LV tunnel. There is a lot of type, and this is type 1 aorta LV tunnel, which connecting the aorta from the sinusotubular junction or above it till the cavity of the left ventricle. And the sure diagnosis is actually multi-slice CT, and the probable management is a surgical intervention. And here the CT of our case, and we can here appreciate the tunnel. And the second question is, what is the actual management or the best option for the management of this case? All of the literature was preferring the surgical closure of the tunnel. بالضبط بالضبط ده رؤية الانترفنشنالست إن we can use any device of label. Actually I think if this boy by any way will go for surgical intervention, so why we try to close it transcatheter, and if it's failed we can send him for the surgery, nothing will be lost. This is the 3D echo for him for good delineation, the anatomy of the tunnel. And here the angio, also we can appreciate the very wide opening of the aorta from here till the left ventricular cavity. And I decide to close it using a Conar device. And here the echo guiding the steps. And this is echo guiding the steps till the device actually put in this cavity, in this tunnel. Here is the angio. We can appreciate here the tunnel. And after taking all the measurement, cut pigtail can cross this tunnel. And I start to put the device from the left ventricular side. And here the deployment of the device. This is the device after closure. And actually in the angio, it looks very nice. But actually, by the echo, it's not nice at all. There is a significant residual flow here, and also there. There is a significant residual flow after putting the device. So the next question, what I can do, I guess I can remove the device and send the boy for surgical intervention. But at that moment, I have another idea, how I can deal with this tunnel. At the same time, how I can deal with the Conar device. The Conar device have a pulmonary end and systemic end, and I deal with the tunnel as the left ventricle is a systemic side and the aorta is the pulmonary side, which is wrong thinking from me. So I guess if I can upside down the device and deal with the aorta as the systemic side and the LV as a pulmonary side, it may be work. I don't know. So I decide to upside down the device first and show what will happen. And actually, this is the result. At anyway, the angio looks to me satisfactory a little bit. So the echo is the guide. And actually, after putting it, I have a certain important measurement to that. First, the aortic valve. I must be away from the aortic valve. Here, the cusp is moving well. I have no aortic incompetence, and this is one of the major aim after putting the device. And the second one is the residual flow. If it's improved or still there, here we can appreciate that the residual flow is actually disappeared. I haven't that residual flow significant that was present in the first position of the device. And here also, there is no residual flow significant as the first position. And here as well, the residual flow is disappeared. So the good thinking in the Conar device may give the results in a different way. After release of the device, it looks to me okay. And 1 year follow-up, there is a marvelous improvement of the left ventricular size and left ventricular dimension, which is the main issue. And now the symptoms of heart failure and NIHA class 2 of the patient is marvelous improvement after 1 week from deployment of the device. Other theoretical issue, recorded complication. Recorded complication even after surgical closure of the aorta LV tunnel. There is a recorded residual flow through the tunnel even after surgical closure, which may be in the future need redo another one because of the growth of the baby make this tunnel gross and become bigger once again, and re-intervention may be also needed. And this is the surgical classification of the tunnel. We have type 1, which is the simple tunnel, slit-like as our case, with no aortic valve distortion. Type 2 of the tunnel is an aneurysmal extracardiac aortic wall component and oval aortic orifice with or without aortic valve distortion. Type 3 is an aneurysmal intracardiac component and oval orifice with or without right ventricular outflow tract obstruction from this tunnel. So the third type come with right ventricular problem, not only left ventricular problem. The fourth type is a combination from type 2 and type 3. The investigation, the mandatory one is the multi-slice CT or CT tomography, which is delineated the tunnel and figure out the morphology to decide which option of intervention is best one. This is the history, all the history for the tunnel, but we have a shortage of the time, so I will come to the take-home message of label use of the occluder devices in the cath lab found to be helpful and safe when chosen according to the morphology, the site, and the size of the lesion, and in considerable a good alternatives to a surgery. Be confident and think outside the box. You can come with a brilliant idea for our patient, and multidisciplinary opinion and teamwork always your backbone in the cath lab. And thank you very much.